Okay, so welcome back to this next video in which we are discussing rheumatoid arthritis and anti-rheumatoid drugs. Okay, right. So we're currently looking at the disease-modifying anti-rheumatic drugs. Okay, and we're now going through some of the stranger disease-modifying anti-rheumatic drugs, which are very effective, but for reasons that are very poorly understood. And the first one that we've seen is penicillamine, okay, which is also called dimethylcysteine, which is just a cysteine amino acid with two methyl groups added onto it. Okay, and we believe that this achieves its anti-rheumatoid function by blocking the synthesis of interleukin-1 by the synovial macrophages, but that is still very shaky. Okay, right. We're now on to some more examples of strange disease-modifying anti-rheumatic drugs. Okay, the next ones that I want to discuss are what are known as the gold compounds. Let me just move this over a little bit. Okay, so the gold compounds coming up next. Okay, right. So firstly, what is a gold compound? Well, literally, it is just a molecule that contains gold atoms. Okay, so the gold compounds that are used to treat rheumatoid arthritis are just molecules that happen to contain gold atoms. Okay, now there are two gold compounds that are used to treat rheumatoid arthritis. One is what's called sodium orothiomyelate. Okay, so sodium oro, and oro means gold. Okay, so sodium orothiomyelate. Okay, and the second is something called auranofin. Okay, so auranofin. Okay, right. Now, they are very effective at treating rheumatoid arthritis, i.e. they do make the inflammation go down, they do reduce the pain, and they do reduce joint destruction. They generally take around 3 to 4 months to work, okay? And we don't really know how they work. We have a slightly better understanding of how auranofin works than we do for sodium orothiomyelate. Okay, so auranofin is believed to work, so I should probably put a shaky arrow there. It's believed to work by making both interleukin-1 secretion and, even better this time, tumor necrosis factor alpha as well. Okay, it's believed to make interleukin-1 and tumor necrosis factor alpha synthesis go down, basically. Okay, so those were the two utterly foundational cytokines released by those synovial macrophages in response to interferon gamma and immune complexes as a result of the autoimmune attack. Okay, and these pretty much drove everything, as we saw. They drove the chronic inflammatory response, they drove the changes to the synovial membrane, the hyperplasia of the synovial intima, the pannus, the extension of the connective tissue so that it now covers the articular cartilage. They drove the degradation of the hyaline cartilage by driving chondrocytes and synovial fibroblasts to release proteases which broke down the type 2 collagen molecules of the hyaline cartilage. Okay, they also played their part in bone erosion by causing synovial fibroblasts and also causing the synovial fibroblasts to express the rank ligand, which then drove osteoclast precursor differentiation into osteoclasts. Okay, so tumor necrosis factor alpha and interleukin-1 was central to the pathology of rheumatoid arthritis. Okay, and if we stop their synthesis, then we're hugely going to reduce the disease, even if we don't actually affect the fundamental autoimmune attack. Okay, right, so that's what is understood of how auranofin works. Okay, next up, we have the anti-malarial drugs, and we know absolutely nothing about how these work to treat rheumatoid arthritis. So all I'm going to be able to do in the case of the anti-malarial drugs is give you their names. Okay, so they are used to treat malaria, these two drugs, more usually. Okay, but they are also effective in rheumatoid arthritis. Okay, so examples of the anti-malarial drugs used to treat rheumatoid arthritis are hydroxychloroquine, okay, and also chloroquine itself. Okay, now these drugs have quite horrendous side effects. Okay, so they are not exactly what you'd call the first line choice of drug for treating rheumatoid arthritis, but they are effective for reasons that are not understood at all. Okay, right. Finally, what I want to talk about is another example, and my final example of a disease-modifying anti-rheumatic drug, which is sulfasalazine. So sulfasalazine, okay, which is quite a popular disease-modifying anti-rheumatic drug, particularly in the UK. Okay, now, sulfasalazine is broken down in the intestine, okay, by bacteria that are in the intestine, okay, into two other molecules, and it's one of these breakdown products that is believed to be the active one that actually produces the anti-rheumatoid effect. Okay, so sulfasalazine then, it's broken down in the intestine into two molecules. One of them is called sulfapyridine, okay, and the other one is called 5-aminosalicylic acid. Okay, so 5-aminosalicylic acid. And it's the 5-aminosalicylic acid that's believed to be the actual active one. Okay, so this is believed to work to produce an anti-rheumatoid function by scavenging free radicals, basically. Okay, so this is a free radical scavenger. It reacts with free radicals and basically stops them from doing damage. Okay, now where did we see free radicals in the pathology of rheumatoid arthritis? Well, remember, when the neutrophils come into the synovial fluid, okay, as part of the chronic inflammatory response and because of the elevated levels of interleukin 8 and interleukin 17, which are powerful neutrophil chemotactic agents, okay, when they came into the synovial fluid, they started chucking out horrible molecules such as superoxide was the example I gave you, okay? And these horrible molecules reacted with the protease inhibitors that are found in all tissues, basically. And they stopped the protease inhibitors from working. And it was by doing that that the proteases that were released by the chondrocytes and by the type B synoviocytes in response to interleukin 1 and tumor necrosis factor alpha. It's by inhibiting the endogenous protease inhibitors that those can actually have effect, basically. Okay, and that's why we got degradation of the hyaline cartilage. So if I just try and find the page where I discuss this, okay, here it is. Okay, so remember, the chondrocytes and the synovial fibroblasts were induced to release proteases by tumor necrosis factor alpha and interleukin 1. And why were these proteases not inactivated by the endogenous protease inhibitors? Well, it's because these horrible free radicals inactivated them. Okay, now, what is understood of the mechanism by which sulfasalazine has its anti-rheumatoid function is that the 5-aminosalicylic acid, one of the breakdown products of the sulfasalazine, stops those free radicals from inactivating the endogenous protease inhibitors, okay, by scavenging free radicals, reacting with the free radicals, and basically stopping them from then reacting with the protease inhibitors. So it saves the protease inhibitors, basically. Okay, right, and that's really all that's well understood about how sulfasalazine achieves its anti-rheumatoid effect. Okay, right, so we're now moving off from what are considered the disease-modifying anti-rheumatic drugs, okay? The next type of drug that I want to discuss is the glucocorticoids, okay? And these work by having both an immunosuppressant activity and also by having a very potent anti-inflammatory activity. Okay, so now we want to turn our attention onto the glucocorticoids, and these are nicer because these have a more well understood mechanism of action. Okay, so these drugs are all rather disappointing, where we can only really learn their names and know that they're useful and not really understand how they work. The glucocorticoids have a very well understood mechanism of action. Okay, so these are not considered disease-modifying anti-rheumatic drugs. They're considered in a separate class. but they work in a similar way to the way that methotrexate, azathioprine, and tacrolimus and cyclosporin work, which is that they produce immunosuppression, which relieves us of the autoimmune attack. And they also work in a similar way to the way we've seen that auranofin works, which is that it stops the synthesis of interleukin-1 and tumor necrosis factor alpha, okay, and therefore blocks the chronic inflammatory response and the joint destruction which those drive, okay? So they do quite a lot of things. Right, so let me start by giving you examples of glucocorticoids. Okay, so one of the most commonly used glucocorticoids is the drug prednisone. Okay, now prednisone is again a prodrug, okay, and it's converted to the active drug in the body, which is prednisolone. Okay, so prednisolone is the actual active drug that's going to have the effect. Okay, another important example of a glucocorticoid that's used is a drug called dexamethasone. And finally, another one is triamcinolone. Okay, now how do these drugs work to achieve an anti-inflammatory and a immunosuppressive action? Well, basically they bind to receptors that are in the cytoplasm. So not receptors that are on the surface of the cell, but receptors that are in the cytoplasm. Okay, now the receptor for glucocorticoids is a cytoplasmic protein simply called the glucocorticoid receptor. And for short, the glucocorticoid receptor is often abbreviated down to the GR. Okay, so this is the glucocorticoid receptor. Okay, now, before the glucocorticoid drug molecule binds to the glucocorticoid receptor, the glucocorticoid receptor is usually complexed with other proteins, okay, and the principal protein that it's complexed with is called heat shock protein 90. There are a lot of other proteins that it's complexed with as well, but we're not going to fuss over those, okay. The principal one that it's bound to is a protein called heat shock protein 90. Which for short is abbreviated to HSP90. Okay, so this stands for heat, that's the H, shock, that's the S, and then P for protein, so heat shock protein 90. Okay, and I'll outline heat shock protein 90 here in vivid purple. Okay, so what's now going to happen then is when the glucocorticoid molecule comes into the cytoplasm of the cell, okay, and these molecules are going to be lipid soluble, so they're going to be able to pass through the cell membrane and into the cytoplasm of the cell. When they come into the cytoplasm of the cell, they're going to bind to the glucocorticoid receptor, and it's going to dissociate from the heat shock protein 90. So what you're now going to end up with is your glucocorticoid receptor here, with the little glucocorticoid drug here, which I'll just abbreviate down to G. Okay, so here's our glucocorticoid drug molecule in orange there. Okay, and here's our glucocorticoid receptor in blue. Now what's going to happen is the glucocorticoid receptor molecules are capable of acting as transcription factors. They're capable of changing gene expression in cells, basically. Now, they don't act on their own. In order to bind to DNA, what has to happen is two glucocorticoid receptor molecules that have each got glucocorticoid molecules bound to them need to dimerize in order to actually be able to bind to the DNA. Okay, so the glucocorticoid receptor will go into the nucleus with the glucocorticoid attached, then they will dimerize to bind to the DNA, okay, and then this glucocorticoid receptor dimer here is going to change gene expression within the cell, okay, and this will be occurring in every single cell that the glucocorticoid goes into, so it will be occurring all around the body, and it will be changing gene expression, and how it changes gene expression is going to vary in all of the different cells. Okay, so in every different cell it will alter gene expression in different ways. Now, which cells are we particularly interested in? Well, we're going to be interested in the cells of the immune system. How is it going to change gene expression within the cells of the immune system, and therefore how is it going to produce an immunosuppressive effect and also an anti-inflammatory effect? So we'll start off with the immunosuppressant effect of glucocorticoids and how that is achieved. So basically, we need to study what the glucocorticoids do in T cells, basically, in order to understand how the glucocorticoids can act as an immunosuppressant. Okay, and I'll get rid of that S there. So, basically, they work in a very similar way to cyclosporin and tacrolimus, which is that they prevent the T cell producing interleukin-2 and interleukin-2 receptor alpha. Okay, and this is how they prevent T cell activation. Okay, they stop the synthesis of interleukin-2 and they stop the synthesis of interleukin-2 receptor alpha. So going back to our activation of the adaptive immune response, if I can find it. Okay, here. Okay, so when we want to activate T cells, remember you get signal 1 and signal 2, and this causes the change in gene expression that then causes the T cell to express interleukin-2 and interleukin-2 receptor alpha, and we've seen that the transcription factor which drives that is the nuclear factor of activated T cells, NFAT. However, basically, if this T cell has been exposed to glucocorticoids, then the glucocorticoid receptor dimers that are bound to the DNA now will stop that T cell actually activating the production of interleukin-2 and interleukin-2 receptor alpha. So basically, even if you get signal 1 and signal 2, it's not going to have any effect, basically. I'm not going to produce the interleukin-2 or the interleukin-2 receptor alpha, and therefore the cell is not going to receive signal 3, and therefore the T cell is not going to actually activate, basically. Okay, and that's how you block the entire adaptive immune system. So just like tacrolimus and cyclosporin, you're going to produce immunosuppression by blocking the activation of T cells, and therefore, given enough time, you will completely stop the autoimmune attack in rheumatoid arthritis using these drugs. Okay, now they're also going to have anti-inflammatory effects, okay, by working on the synovial macrophages. Okay, so remember the synovial macrophages responded to those molecules that were being produced by the adaptive immune system cells in the subintima. Okay, so the interferon gamma and the immune complexes. Basically, what glucocorticoids are going to do in those synovial macrophages is they're going to stop them actually producing all of these pro-inflammatory molecules. So for instance, they're going to stop them producing interleukin-1 and tumor necrosis factor alpha. Okay, and those are the two primary cytokines. They will also have effects on some of the other molecules that the synovial macrophages produce, but those are the absolutely primary ones to the chronic inflammation that occurs in rheumatoid arthritis. So glucocorticoids are also going to make the expression of interleukin-1 and TNF-alpha by the synovial macrophages go down, and therefore that's going to have an effect on the inflammation in the joints. It's going to reduce the inflammation and therefore reduce the swelling. It's going to reduce the production of prostaglandins and therefore reduce the pain. Okay, by other mechanisms beyond this. Okay, it's also going to prevent joint destruction, because if you've no longer got the interleukin-1 and tumor necrosis factor alpha, remember those are what drive the changes to the synovial membrane, the breakdown of the hyaline cartilage, and the bone erosion. Okay, so you're going to prevent further destruction to the joint. Okay, and I would just like to mention how they're going to reduce the synthesis of prostaglandins, since I just said it. Okay, they're going to reduce the expression of cyclooxygenase 2 within those synovial macrophages, and therefore reduce the amount of prostaglandins that you can synthesize. Okay, because cyclooxygenase 2 is the main one that can convert arachidonic acid into prostaglandin H2. It is fantastic at doing it. It works really, really quickly, whereas cyclooxygenase 1 is a bit pathetic at doing it, basically. It works really, really slowly. Okay, so if you stop the expression of cyclooxygenase 2, you can hugely reduce the amount of prostaglandins that cell is capable of producing and secreting. Okay, right, so there are the glucocorticoids and how they are going to have very powerful anti-rheumatoid effects. Okay, we'll call it there for this video, and then in the final video what we'll talk about is the biopharmaceuticals, okay, which are mainly monoclonal antibodies directed against certain proteins involved in the pathology of rheumatoid arthritis, and they are incredibly effective at treating rheumatoid arthritis.